Let's start Bismillah. We have done pancreas.
Yes.
Okay. What is left is the biliary tract or biliary apparatus. These are the common names for biliary tract, biliary apparatus. Before I jump onto the biliary apparatus, try to see this picture and try to remember it till the evening of Yom not the morning. Evening. Once everything is done, still you should remember. Okay, Bismillah. So here is this is the liver. Okay. This is the liver. It has two lobes. Right lobe, left lobe.
Yes.
Good. Then inside one light, please. I need some lights to show you. Okay, that's good. It's good for you? Visible?
Yes.
Okay. Inside the liver we have small channels. Intrahepatic biliary channels. Intrahepatic biliary channels you will read in histology. There are triads and like this.
Yes.
These biliary channels will make two big ducts. One here, one here. Right hepatic, left hepatic. Good. This is right hepatic, left hepatic. This is the first drainage or first distribution from the liver. Both of them they unite. So let them unite here, here. And they make one duct, common hepatic duct. Okay? Let me give it a different color. So, common hepatic duct. So right hepatic, left hepatic, they combine to form the common hepatic.
Yes.
Now, below the liver, there is a gallbladder. Marara.
Yes.
Okay? It also has a duct. This is known as cystic duct. The cystic duct joins common bile duct. Okay? Sorry, common hepatic duct. Sorry. Right hepatic duct, left hepatic duct, they will make common hepatic duct.
Yes.
The common hepatic duct joins with cystic duct of the gallbladder. This gallbladder. Join and make common bile duct. Let's make a big one. Common bile duct, CBD. Some books say bile duct, okay, no problem. Some clinicians say bile duct, no problem. But common bile duct is usually the anatomy name. Okay, common bile duct. Now, after you will find here this duodenum, C-shaped duodenum. I told you it has four parts, D1, D2, D3 and the elevated part, D4 part. Now, in the C of, this is the C, concavity of C of the duodenum, here we have pancreas. Head, body, tail. Good? Now, pancreas has a duct. The main duct. Suppose some accessory duct also, but forget it for 1 minute. Only think of the main pancreatic duct. Now this main pancreatic duct will unite here behind the duodenum, reach the head of the pancreas, and then it will open into D2, the second part of duodenum. This is the overview for all the lecture today. Now, in the duodenum, if I make this a big duodenum, D2, here there is an elevation. Elevation yani, if I open the duodenum, you will find an elevation. This is ampulla. And then you will have an opening duct. That will open here. Okay? So ampulla effvator. Now, this is controlled by hormones. There is no valve until we reach this region. There is a thickening of muscles and that is known as sphincter of Oddi. Sphincter of Oddi is here. This is the overview for all the lecture today. Again, right hepatic, left hepatic. Always remember the bile. Even in Jannah, the bile will be secreted by liver. Inshallah. So right hepatic, left hepatic ducts, they will join to make common hepatic duct. Common hepatic duct will join cystic duct to make common bile duct. Now the common bile duct will cross all these pathways. So this is roughly 7 to 10 centimeters. Right hepatic, left hepatic are very small. Common hepatic and this, they are roughly 3 to maximum 4 centimeters. This one and this one. Nearly parallel in size, nearly. These are very small, even less than I think 1 centimeter or so. So this is what we are going to deal today. So Bismillah, let's start. Now most of the things you will be knowing. We will be skipping all these theoretical parts now. Okay? Inshallah. I'm thankful you are here still. Because I was really busy in some other issues. So now I started at home. Okay. So biliary apparatus is composed of right and left hepatic ducts which unite to form common hepatic duct. Life is easy. Gallbladder. So these are the parts of biliary apparatus or biliary tract. Right and left hepatic ducts. Here we have right and left hepatic ducts. Right and left hepatic ducts. Then we have a common hepatic duct. Common hepatic duct. Then we have a gallbladder. Then common bile duct. This is cystic duct. This is joining part, and here is the common bile duct, which will come and open into the second part of duodenum along with the main pancreatic duct. Clear? Good. Common hepatic duct. This one. We are still ignoring the right hepatic, left hepatic because these are very small, attached or in very close association of the liver. At the end we have some lab pictures. I can show you here and there as well. So common hepatic duct, this is common hepatic duct. Union of right and left hepatic ducts near the porta hepatis. What is porta hepatis? Hilum of the liver. Where is the hilum of the liver? Let's see if I have any picture of the liver. Here roughly. This is the hilum of the liver. This is the hilum of the liver. And in the lab I will also demonstrate to you hilum of the liver. Okay. Relations to the right of the hepatic artery and anterior to the portal vein. Okay. Ends where joined at an acute angle, yani takriban 90, Zawiya of 90, with the cystic duct to form common bile duct. And this is about the common hepatic. Gallbladder. Gallbladder is a reservoir, is a storehouse for bile. The bile is secreted by liver. It's not secreted by gallbladder. Gallbladder only receives the prepared. One function of the gallbladder is to make it concentrated. When the bile is coming from the liver, it is stored in the gallbladder. The gallbladder make it more concentrated, more kasif. Absorbs the water and it makes more thicker sort of a solution. That is the reason when it is overstimulated and over thickened, or you are fasting for more than 12 hours, there is a possibility of more absorption, and that is the point where you can get stones because of crystallization. If there is more dryness, you can land up into crystallization. Small crystals can be visible in gallbladder, and later on they can turn into small stones. We will see them in a couple of minutes. So gallbladder, so the function of the gallbladder is only to receive and make it concentrated. Plus with the hormone cholecystokinin, pancreozymin, when it contracts in response to food here in duodenum, lipid food, then it will contract and it will try to release the content so that it can reach the fat and it can start digestion. These are the basic things for gallbladder. So what is gallbladder? It is piriform, fibromuscular sac, pear shaped. Commissary is good for pear. Okay. Dimensions 7 to 10 centimeters like this, and 3 roughly broad. Capacity maximum is 50 ml, not beyond usually. So if the bile is still coming and you are fasting, so ruptures are rare until it is highly inflamed stone or trauma or something. But still possibility is there. So after 50 ml, it will start concentrating. So getting out the water and get the more bile. So this is the reason. Then peritoneal covering covered posteriorly continued from hepatic surface except fundus, which is completely covered by peritoneum. So this is liver. Here is the fundus of the gallbladder. This part is the fundus of gallbladder. Here you will find the fundus of gallbladder. To me, just behind the anterior abdominal wall at the level of T9, tip of the costal cartilage, I will find the fundus of the gallbladder here. It is just anterior to the abdominal wall, nothing else, okay? So anterior abdominal wall is here. Parts, fundus, the part which is visible here is the fundus. Then I have to lift the liver like this, and the fundus goes up, and you will find a body, and then you will find a neck, the constricted part, And then you find a duct known as cystic duct, which is spiral in shape. So can be a bit elongated. They say it is valvular. They say it acts as bivalvular. The contraction of the gallbladder leads to evacuation or the discharge of the fluid. Plus, near the neck we have a small part which is known as Hartmann's pouch. It is like a pouch-like extra area structure, which I believe is a gift from Allah subhanahu wa ta'ala to stop the stones here and don't let them go inside the duct. In any picture, in a next picture, I will show you the Hartmann's pouch. Parts of the gallbladder: fundus, it's a blind end near the margin, lower margin of liver. Relations: anteriorly, anterior abdominal wall, and transverse colon is on the back. So here is the liver. This is a side view. Here is the fundus of the gallbladder, anterior abdominal wall, and the GIT part on the back. Surface anatomy is important because the pain of the gallbladder is felt here. So it is the tip of the 9th costal cartilage. How I should read the 9th costal cartilage? The same old rule. I should make sternal notch, then angle of Lewis, and then I will start counting intercostal space. The second intercostal space corresponds to the angle of Lewis. And then I will reach the 9th costal cartilage. On the level of 9th costal cartilage, at the transpyloric plane, and the third margin is the rectus abdominis, the lateral wall, which is known as linea semilunaris. I will show you another picture. Body, here is the body. Then neck, mucous membrane presents the spinal band. Okay. This is just to show you the fundus of the gallbladder with, and here is the surface anatomy. T9, tip of the T9 here, with transpyloric plane and the linea semilunaris. So linea semilunaris, transpyloric plane, tip of the costal cartilage on right or left side? Right side. Until you have a situs inversus. Situs inversus is a situation where all the right things, the right hand is on the left hand. Okay. So this is the same to show you the tip, transpyloric plane, and the line of the rectus muscle, linea semilunaris. Linea yani line, semilunaris like a half moon. Linea semilunaris. Okay. Overview quickly. Fundus, body, a neck, spiral cystic duct, right hepatic duct, left hepatic duct, common hepatic duct. Now, this is common hepatic duct with combining with cystic duct, making you common bile duct or bile. Okay, cystic duct of the gallbladder, this one. Here is the Hartmann's pouch. See this one? So this is fundus, body, neck. In the neck you have this extra part. See this. This extra part is known as Hartmann's pouch, and I believe myself personally that this is when the gallbladder has stone and when it is contracting, the stone is less likely to go here, and probably this is the gift from Allah subhanahu wa ta'ala to stop the stones, because if every stone starts going here, all of us should be having, all the gallstone patients should be with obstructive jaundices, but they are not. They are only stones but not obstructive jaundice. So this is probably the reason. Cystic duct of gallbladder is roughly 3 to 4 centimeters here, and I told you the length of the common hepatic and this is roughly the same. From neck to join the hepatic duct to form the bile duct, common bile duct, its mucous membrane presents 15 to 20 crescentic folds like spirally arranged, and they also act as a spiral valve. Hartmann's pouch is this extra structure or outpouching at the junction of neck with cystic duct. This is a normal anatomical feature. Blood supply of gallbladder and this part. You know aorta, you know celiac trunk. From celiac, this is the aorta, here is the celiac. From celiac, I have 3 main branches. One, common hepatic. one splenic, one left gastric. So 3 main branches. Forget the 2. Focus on the common hepatic. So first, common hepatic. Common hepatic will divide in 2, right hepatic and left hepatic. The right hepatic will give branch to cystic. See here. Celiac will give you common hepatic. Common hepatic divides into right hepatic, left hepatic, and right hepatic will give you branch for the cystic. And the name is cystic artery. Cystic artery commonly arises from the right hepatic artery, where in the triangle of Khalid, this is the triangle of Khalid, between the common hepatic duct, cystic duct and vessel surface of the liver, this is the boundary of this triangle of Khalid. Important during surgical interventions of the liver. Variations occur in the origin of the cystic artery, many variations from here, small, big branches. But this is the classical way. Celiac trunk, common hepatic, 2 branches, right hepatic, left hepatic, right will give cystic. Venous drainage, where it should go? Portal, because the nearest vein here will be the portal vein. This is the liver. So right here it will make a vein. Here we have portal vein. It will go into the right branch of portal vein. I will show you in a minute. Okay, by cystic artery, and you know it. The cystic vein ends in the right branch of portal vein. Khalas? I write here other arteries because there may be some variations, no problem. But ultimate is from cystic, celiac is the arterial supply and portal is the drainage, ultimately in all the cases. Nerve supply of the gallbladder. Of course, a visceral organ, so it has a sympathetic and a parasympathetic. Sympathetic and parasympathetic fibers derived from celiac plexus, which is around the celiac trunk or celiac artery. Then some fibers from phrenic nerve, and that is the reason of tip. Whenever there is a gallbladder pain, the pain is referred to the tip of the shoulder or sometimes to the scapular region also. So this is the reason for this referred pain. Gallstone, obstructive jaundice, you know. We will have a couple of slides to show you in a minute. Lymphatic drainage of the gallbladder ultimately reaches where? The celiac lymph nodes, because the source of the blood supply is here. Am I clear? Yes. Anything you know? Any questions? Anything? Any problems? Good. This is just a picture to show you the celiac. See here, the aorta, the celiac, the common hepatic, right hepatic, left hepatic to cystic, and then the portal vein, and nothing new here. The most common disorder of gallbladder is probably the gallstones. Probably. I am not sure, pathology people will reconfirm this. Gallstones is the commonest problem with the gallbladder. And the reason is, again, the same concentration. In the new era, we are dealing with some gaps in the feeding habits like keto diets and blah, blah, blah. One of the risk factors is gallstones. Because of prolonged starvation, it can land up into. This is a possibility. Once the stones are formed, unfortunately, initially they stay here. If the stones are small, they have a tendency to pass through the cystic duct. They may be stuck in the cystic duct, or they may be passed with the pressure into the common bile duct, and then they can stuck. So they can stuck in the Hartmann pouch, then they may stuck. Until the Hartmann pouch, I should say they are safe. They are not safe, but I should say they are still safe rather than to pass here. Then after that, in the cystic duct, it's again a problem. After, it's still a problem. So this is going to lead a back pooling of secretions, bile which is not able to reach the duodenum. Now the bile will stay inside the liver. And this is one of the objective in my objective of one of the one of my PBL group today, how this will reach the skin to cause the scratch marks in your PBL. So let's wait and see. Okay. Here, before it terminates into, again, the sphincter of Oddi is a possible place for obstruction or impaction of the stone. So these are the possible areas. Small stones are bad or big stones in gallbladder? Big. Very good. Why?
Can cause obstructive.
Small stones are good or big stones are good for gallbladder?
Neither are good, but small are less.
Yes, neither are bad. Both of them, they are bad. Yes, of course. But the small have the tendency to pass through the tube. If a stone is big inside, for example, like this here, so these small have the tendency to cross. The big will come here, and when the gallbladder is still relaxing, come back. So still big is, neither of them is good, but still the big is better. Okay. Here, we can have multi, yes.
Could it be big enough to rupture?
Usually not, because with the time they don't have very sharp edges. They are not spikes like. So if there is a spike, it can. But until there is a severe pain, so the contraction fails after that. So that is the reason. Have you seen some windows of your car? If you put a hand and it will come and go back. So it's the contraction is the aborted or something. See, various type of stones in a gallbladder, small multifaceted stones filled with a bile, and they can reach. They can be multiple, even hundreds, small stones, 100. Okay, common bile duct, this structure, common bile duct. You know most of the things. I told you it is roughly 7+ centimeters. So it is 7.5 long, formed near porta hepatis by junction of dash and dash. What? And okay. 3 parts in relation to duodenum. Here we have duodenum. In relation to duodenum, we have 3 parts. Above the duodenum, so supraduodenal part, behind the duodenum, retroduodenal part, and the pancreatic part, which is in relation with the pancreas and the duct. So supraduodenal part, free border of lesser omentum, it's present, and hepatic artery to its left and portal vein. You can read it. Retroduodenal part is the part which is behind actually the duodenum, behind the first part of duodenum. And pancreatic part behind pancreas, between it and second part of duodenum. The last part is, so if I try to divide, this first initial part is the supraduodenal part, retroduodenal part, and pancreatic part. Again, right hepatic, left hepatic, common hepatic, cystic, making common bile duct, 3 parts, supraduodenal, retroduodenal, pancreatic part. Okay? Plus, see here, celiac trunk, common hepatic, right hepatic, giving branch to, along with some variations, of course. Same thing, nothing new here. Just to show you a real anatomical, the liver was like this. So we just lifted the liver to show you the fundus, body, neck, and other some tubes, and the possible pathway of the stomach, first part of duodenum. So here is the back, here is the second part, it will go and back. Ampulla of Vetter, common bile duct joins the main pancreatic duct. Here is the main pancreatic duct, so the common bile duct join here, forming hepatopancreatic ampulla. Another name is ampulla of Vetter. Opens into major duodenal papilla, 8 to 10 centimeters distal to pylorus. And these measurements I have shown you in one of the previous lectures like duodenum. They asked me automate, but in the practical I still showed you, and that is the reason. This is the importance of. Smooth muscle fiber surrounding the terminal part will make a sphincter known as sphincter of Oddi, like this, sphincter of Oddi. Controlled by sympathetic parasympathetic systems. Bile duct also can has variations. Length, size, dilatation, connection. So they can have a lot of variations. Okay. Now here are some certain things which you can guess. Gallbladder, yes. But it is filled with a dye. It will never appear like on a plain X-ray. On a plain X-ray, only the white things are calcium-containing items like bones. So calcium containing items. So here it's not a plain X-ray. Some dye has been injected. So intravenous cholecystography. We inject a dye which has a sensitivity towards the liver. Now it will be excreted by the liver, concentrated in the gallbladder, and we will take a picture of the gallbladder. This is the story. Plus, when we gave him a lipid food, it will contract and it will give you all the structures. Okay? This is one method of investigation. Now you can guess some areas. Where is right hepatic and left hepatic? Up here, probably this and this. So think liver is like this. Right lobe, left lobe, right hepatic, left hepatic. Common hepatic. Common hepatic will join the cystic duct. Why the gallbladder is not visible here? Because it has contracted. After we played with him, we gave him a lipid food and contracted, so it is not much visible. But now the cystic duct is nicely visible, and now the common bile duct. But what is this happening? Splash. In the duodenum, we have an open channel, so the whole dye is being excreted into the duodenum. This is one way of investigation, intravenous dyes, and we can do it like intravenous. Am I clear?
Yes.
Good. Another method is endoscopic retrograde cholangiopancreaticogram, ERCP. What is endoscopic? I passed an endoscope. Retrograde. How to inject the dye inside? Think, common sense. Common sense is very uncommon. This is the problem. Okay, let me explain. Take a patient. I want to investigate the gallbladder. Take a patient, put a tube. Don't try it home. Put a tube, endoscopic tube. Pass through esophagus, stomach, reach the duodenum. Now, from here, you reach the duodenum. From here, you will reach the D2. Now you will locate the ampulla. Find the ampulla, inject. Now the dye will reach everywhere. So this is known as retrospective, because I am going opposite. So endoscopic retrospective cholangiopancreatogram, ERCP. Now try to identify the things. Gallbladder with some cystic duct, hepatics maybe here, joining of cystic and common hepatic, making common bile duct, opening into duodenum. What is this? Transverse colon is so bright. It's Yom Eid or what? It is the scope. It is the endoscope which is coming from stomach, duodenum, second part. It reached the ampulla. And now here is the ampulla of Vater. It will inject and the dye is going in. Understand now?
Yes.
Clear now? So endoscope, you know the two methods now. Injectable and this retrograde, endoscopic retrograde, ERCP. Good?
Good.
Okay. You are very familiar with this.